Hi, good morning. My name is Gerard Ilaria. I'm a licensed clinical social worker, and I work at Weill Cornell Medicine, which is the medical college of Cornell University and is located in New York City, New York. Today, I'm going to talk to you about the role of enhanced resourcing in EMDR treatment of addictions and compulsions. Um, I just want to say I hope that you're having a great conference so far, and I look forward to offering you some information, hopefully, that you haven't had before. I'll talk a little bit about my experience, but I've worked for a long time in trauma and in addiction, and I think that there's many things that EMDR can offer our clients, whether it's in its totality or essential elements of EMDR. Okay, so this is me and a cannoli. I'll talk about the cannoli in a minute, but a little about me. I came to New York in the late 70s, got my undergraduate degree at Columbia College at Columbia University, started working in business, and then was sort of called back to do my social work degree at Columbia because of what was then a raging epidemic, the AIDS epidemic, which was impacting my community as a queer man at the time. So I went back, I did my graduate work at Columbia and immediately started working in AIDS in 1988, which was a time of great trauma and loss. I did that, worked in AIDS off and on for about 25 years. And then subsequent to that, while I was doing that, I was also overseeing addiction programs, and then eventually did about 10 years of EMDR work, specifically with returning Iraq and Afghanistan combat veterans through a program that my colleagues and I stood up across the country, where we had 250 EMDR therapists, and we saw over 2,000 veterans over a span of 10 years, treating them with EMDR, which was very gratifying and very helpful. And then more recently, I've been doing all types of trauma work. I'm focusing a little bit more back on the LGBTQIA plus community, but having a blast with my colleagues who are addiction psychiatrists, EMDR trained, as well as EMDR trained licensed clinical social worker, psychotherapists. So that's a bit about me in terms of my professional life. The cannoli. So why the cannoli? If you look into my eyes while I am anticipating eating this cannoli, I think you see a little bit about what our clients experience as a flood of dopamine in anticipation of doing either an addictive behavior or a compulsive behavior. I'm not addicted to cannolis, but I do look forward to this cannoli all year long. It's at the San Gennaro Festival in September in New York City. There's something about it that is nostalgic. There's something about it that I attribute great, I get a lot of joy from it. But honestly, and we'll get into this more later, it's not biting into the cannoli. It's thinking about the cannoli. It's planning for the cannoli. And that's what you're seeing in my eyes here. And so I'm being a little funny about it, but I have a addiction, lived experience with addiction. Happily not now, but I do go for a good cannoli every once in a while. Okay, so in terms of definitions, the ASAM, which is the American Society of Addiction Medicine, defines addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. And people with addictions use substances or engage in behaviors that become compulsive and often go much longer and beyond where it's useful. And people have harmful and terrible consequences often. That is basically what the definition is. What you don't see in this definition from ASAM is anything about people being weak or people not being of good character or anything else, which probably are some of the narratives that our patients carry with them as they enter our offices to seek care for their addiction or for their trauma. And that's why my approach always is a biological approach. And I do a lot of psychoed, a lot of neurobiology teaching, because I think it's very helpful both to be accurate about what's going on in our clients' bodies, but also to give them some distance from what may be introjected morality that they don't really need and doesn't serve them, and really just makes them have more of a right brain response to this as opposed to a more measured response. So this isn't going to be a surprise to anybody here, but there's a very strong link between early adverse childhood events and adulthood substance use. The ACEs study, at least 60% of people have at least one adverse childhood experience, and 17% have four or more. Those are our clients, and things like child abuse, neglect, family dysfunction are all strong predictors for adult substance use. I think if we do a good job when we're doing our history taking, and I'll talk more about that later, we can really help to figure out what is going on here. But people are typically getting involved with compensatory behaviors or self-soothing behaviors very early on in their life. Okay, so this slide is sort of talking representing that two things are going on at the same time. Clients will come in to see me and they really want to address their disturbing memories, their intrusive memories with EMDR, with standard protocol EMDR, going back to root memories to help stop the pressure on their nervous systems that's really making life very uncomfortable for them. At the same time, though, what's going on the right of the slide is the cycle of addiction, because typically, clients are coming in already using some substances, whether it's alcohol, cannabis, or some behaviors like gambling or porn addiction, to help them self-soothe to deal with their trauma. So, through learning, operant conditioning, and neuroplasticity, clients end up engaging in these behaviors which distract them from their trauma memories, but they're generating their own stress and pain. So I think the takeaway is, and this is born out of personal experience when treating patients, they may say, I've got to work on my sexual assault at 18. That's the cause of all my problems. And they want to start now, today. And there's a strong temptation to want to be able to help people not be in pain over things, especially when they're so focused on the treatment and you're all ready to do the work. But what is often underappreciated is that there's a high probability that if you do something that they've never worked on with a power tool like EMDR, they're gonna become very dysregulated. And if they don't have big time addictions or compulsions, maybe they can be okay with a support network. But I think you really need to be giving people adequate resourcing so that and know enough about them, and also honestly what it is they're doing when they're not with you, to avoid them getting involved in a relapse or something very painful that you may not anticipate. So this goes over a little bit of what I want to do with this talk with you today. And I'm going to cover these items one by one. I'll do it through slides. At the very end, there's about a 20-minute video where I work with a client of mine who's very generous and is willing to have his image seen. And you'll get to see one of the resources that I use to help people with unwanted behaviors. But what we're going to do today is go over using resourcing to help clients to determine what's their level of motivation for change of the addictive or compulsive behavior. Also to teach them stabilization, including affect regulation, emotional regulation. Third, facilitating engagement in broader supports for sobriety. Many people think, well, I'm just going to go to my once a week psychotherapy and that'll be enough and I'll work on my addiction or my compulsion. It's usually not enough. And I'll talk more about that and why I think that that's true and how we can use the EMDR to help them plug into more supports. We're going to help with reprocessing of relapse memories, specifically memories that maybe are fresh or recent events for them, if you will. We're going to help them with address addiction shame, which is sort of its own shame that comes about through perhaps a lifetime, or participating in behaviors that they don't feel good about. We're going to target specifically craving and triggers for use. So both the strong pull to use, as well as what might be the elements in their environment, either externally or internally, that are triggering them to use in the first place. And finally, we're going to identify and strengthen adaptive coping mechanisms that can take the place of their addictive behaviors. So, as I said before, EMDR trauma memories are very painful, and trauma survivors, will look to use substances or compulsive behaviors to self-soothe and seek relief. And Francine Shapiro recognized this early on in her first paper in 1994 on EMDR to treat PTSD in substance users. Since then, there have been, by my count, when I go through the journal, 14 peer-reviewed published articles in the Journal of EMDR addressing addictions to alcohol, substance use, specifically GHB, which is a drug, gambling, and internet addiction. And there probably have been more published since I last counted. And the adaptive information processing model predicts that dysfunctionally stored and not fully processed memories are the cause of several mental disorders, including PTSD and substance use disorder. So how might EMDR resourcing, using its essential components, address something as complicated as the cycle of addiction? So addictions and compulsions come about to escape pain and to alleviate suffering. And that's physical pain, psychic pain, a teenager escaping bullying or ostracization, an adult escaping adult issues, rejection, grief. The brain's reward system will quickly respond in a setting like that with, to help the client escape from pain and suffering and move them towards excitement and reward. So what do we need to know about the brain to help with this? So pictured here is Nora Volkow, who is a physician. She's the director of the National Institute on Drug Abuse and has been there since 2003, still is there. And she has done an enormous amount of work on helping us understand, specifically through brain imaging, so putting people in scans, et cetera, and really looking at what's going on in the brain with regard to addiction. And she describes that the neurobiology of addiction has to do with three phases. One is the binge and intoxication phase, first taking the drug or participating in behavior and anticipating it. Second, withdrawal and negative affect phase as you're coming down. And third, the preoccupation and anticipation phase when you're back seeking again. So specifically, let me just go over these because it's worth knowing a little bit more about it. And again, if you can explain this to the client, it goes a long way to de-shaming this process. So in the first stage of binge and intoxication, and I'm going to refer to notes here because I want to get this right, and I only play a neurobiologist on TV. I'm not an actual neurobiologist, but you hear a lot about dopamine. The neurotransmitter and hormone dopamine floods the brain's reward system, kind of like in my cannoli picture, and results in positive reinforcement between taking the drug or doing the behavior and the big hit of dopamine. But if that just kept going on, we'd be in bliss, eating cannolis all day long. Cannoli is a bad expression. Let's say crystal meth or alcohol or cannabis in this case. That doesn't happen. You don't just keep binging and keep feeling great. What happens is the dopamine is released in the nucleus accumbens. And like with a lot of systems in your body, homeostasis needs to be reestablished. So what happens is dynorphin, which is another neurotransmitter, turns on, and it decreases, it turns off the dopamine in the reward system, which makes the reward system less sensitive to the drug, to the behavior. So it becomes harder and harder for the client to achieve euphoria using the same amount of addictive substance or behavior. So they use more or they go back for more. So once this happens and the dynorphin turns on and the dopamine gets turned off, your client's now in withdrawal or negative affect, negative emotion. This is why each time the client takes the drink or the drug or uses porn or gambles, the brain's reward system needs a little more of the substance or a little more of the behavior to get a similar level of euphoria. And then as soon as they reach that high, similarly, the dopamine's turned off, down their mood comes, even lower than when they started. Hangovers, low mood. So at the same time, the amygdala, our friend the amygdala, the alarm system, switches on, and here comes fear and pain. And the result of negative emotional state leads to activation of all the brain stress systems. So now we've got the decreased sensitivity to the reward, so tolerance, and we've got a lot of bad negative emotions going on. So now this progresses to negative reinforcement because the individual keeps engaging in the behavior to avoid the negative emotions. So you can see how the cycle, is created, and it's the anticipation of the reward, as I was saying before with the cannoli example. It's thinking about the cannoli already. Everything has started. You don't have to get anywhere near the drug before this whole process is already starting. And through behavioral conditioning, it fuels the behavior. So now the impulsive behavior has shifted to compulsive behavior, which in the model here is referred to as chronic taking or seeking. And what you got is negative emotions like anxiety, depression, dysphoria, irritability, which make you want to take more drugs. Finally, in stage 3, preoccupation, anticipation, you're in craving. You're thinking about craving, or you're craving the drug or the behavior. And here's the funny thing about craving. All of this stuff I've been describing has been happening further back in the brain, but suddenly now your prefrontal cortex, the gray matter just above your eyeballs, is impacted because not only is the reward system, which is further back, activated, but now it's impeding on your ability to execute on executive functioning in your front brain. So what does that mean? Executive functioning, prefrontal cortex is for motivation, self-regulation, self-control, delaying reward, and other cognitive functioning. So even when we know the negative consequences, because we've been through this cycle before, our front brain is impaired and the executive functioning is impaired, which leaves our clients vulnerable to continued use. So, if you hear people say, think through the drink, or why would you do that? You know where you've gotten before. The problem is once this cycle starts, your prefrontal cortex is impaired, and you really can't just call upon cognitive functioning as easily as you could, let's say, when you aren't in this cycle. So they're vulnerable to addiction, usually through 2 ways. Cue-induced reinstatement. So when you see something, you're reminded of something that triggers your desire to use, or stress-induced reinstatement, where, again, maybe internally or something happens where you become stressed out and you want to seek relief. So if either of those things happen, you're vulnerable to use again. And, neuroimaging studies, reinforce this and have for all these years. And this is how we think about it. And when you think about these different places where this cycle is happening, it also can inform us as to how we're going to use resources to fix this. So getting started. So one thing that I do that I think maybe a lot of other people don't do, but maybe they do, is that I introduce alternating bilateral tapping or alternating bilateral stimulation very early in the process of doing the work, so early that you might be surprised, like phase 1. So before history taking, during history taking, during assessment and treatment goal setting and planning, I am having them tap. Why am I doing that? Alternating bilateral tapping engages the parasympathetic nervous system, so it relaxes them, and they're more likely to be able to stay in their window of tolerance. If they can stay in their window of tolerance, they're not going to run out of the room, and they're also going to be able to, since we know that alternating bilateral stimulation helps with engaging or integrating both sides of the brain, including the left brain, which is logic and reason, we've got more availability of, their whole brain rather than just a reactive right brain. When I'm doing history taking, in addition to biopsychosocial history taking, I want to take a full drug and alcohol history. And that often comes with a lot of shame. People are nervous about sharing. They don't want to tell you the extent. They want to appear, like a good patient, or they just have never shared this before. And I find that by either tapping or using, remote tappers or something, they're much better able to stay in their window of tolerance and maybe really tell me all that, we need to know. Additionally, with sexual history taking, I want to know about early sexual behavior. I want to know about masturbation, use of porn, later sexual behaviors. I want to know about a history of use of food to self-regulate, either restricting or binging, or just how they might use food. I want to know about thrill seeking, danger. I want to know about self-harm, gambling, shopping, anything else that they may do in a repetitive way to self-soothe, but that has become problematic over time. It's really important to destigmatize these behaviors because, again, this may be the very first time that a client is telling anybody about this stuff. And the more I have them in their body, the more I have them relaxed and in parasympathetic state, the better chance I'm going to have of them even coming back or continuing this work. I also want to access all of their environmental supports. So I need to know, are the people around you interested in helping you towards this goal of modifying or stopping this behavior? And this can be family, loved ones, mentors, other supports that can be counted on to assist with behavior change and to offer emotional support. I also really need to know if there's anybody in the client's immediate orbit that is going to mostly work against this change. And that could be a spouse, for example, who's still using, or a group of friends that will, through peer pressure, make somebody feel bad about stopping or modifying behavior. And it's also important to know that, they're going to need round-the-clock support, meaning coming to see me once a week or twice a week, or even an IOP. Let's say they're in for 5 hours or 10 hours. There's 24 hours in a day and 7 days in a week. And at any one time, the client can become stressed or experience craving and have access to the behavior or the substance and use. So we want to try to help them develop more resources, either through groups or formal groups like 12-step programs or other types of supports that are going to be there when I'm not there for them as the therapist. I want to know about quantity and frequency of use. And again, alternating bilateral stimulation is going to be very helpful here because it might be embarrassing for them to tell me about the quantity that they use or how frequently they use porn, for example, throughout the day, or how much shopping they're doing, how much they've spent, etc. And I also want to know where have these behaviors taken them? So how bad did it get? Did they end up in the hospital? Have they blacked out? Have they become ill? Have they run up a huge credit card bill? Was there a big fight or a rift in their friendship group or in their family? Or is there a legal consequence? This is all information that when they let me know about it, is going to be difficult for them to share, and is going to make them dysregulated as they think about it. So having the alternating bilateral stimulation going through self-tapping or whatever is going to be very helpful to get this. And finally, readiness of change. if they came in because, they crashed the car, or the wife said, or the spouse said, get out, unless you get treatment, they might be ready front and center to do the work. If, however, they're coming in and they, are less interested in that, or if they really came in for the trauma, but not that, it may be a long time before we teach them more adaptive coping mechanisms, because maybe the last thing they want to do is give up the one thing that's working to self-soothe them. So, one thing we want to do, now that we've got them tapping, now that we've, started to get them to understand that they can regulate their own nervous system, we want to find out from them, what are things that you already do or you have done in your history to self-soothe, that are adaptive, that are not going to get you in trouble. So I might ask, at any point in your life, what adaptive behaviors, what activities have brought you joy or relief? And they might say, I used to enjoy swimming every day or going to the beach. I loved walking outside in nature. I loved gardening. I love to play the drums. I used to paint. I used to journal. And if they're having trouble recalling any of these adaptive strategies, you can help them. You can menu for them a little bit. And, there are a lot of them, and you can share, for example, in these slides, ways to get some of the neurochemicals that they've been getting through substance use or through addictive behaviors or compulsive behaviors can be gotten through other ways, like exercise, watching something funny on TV, completing a task, getting good night's sleep, listening to upbeat music, going for a walk, getting sunshine, teaching them meditation, cardio, using their pet, getting a hug, cooking for somebody that they love, holding hands. These are all ways that you can get hormones that are really helpful for you that are not prone to negative consequences. Once you've got a list of 4 or 5 such behaviors that they can use that are adaptive, you can have the client imagine doing a behavior with the addition of bilateral tapping through buzzers, knee tapping, butterfly hug, etc. Asking the client to do so with eyes closed can help the client connect more deeply to the positive adaptive behavior in an imaginal rehearsal way. And they can resource the imaginal behavior silently, or they can describe it. You're going to be watching for distress or positive affect in their face and body. And you can either have them stop tapping and check in with how that felt, where they noticed it in their body, positive sensations. And if it goes well, in general, you could just say, would you like to strengthen it? And have them continue to tap with eyes closed. If at any point there, as in with any resourcing, it goes negative or goes south, you could have them stop tapping and either change the memory, or I should say, change the imaginal rehearsal of the behavior to something else, shorten the sets, and continue on. And just check on their work, see where it works or doesn't work, keep retrying it. And they can practice this, and you could practice it with them in office. Sometimes you can't do heavy lifting of trauma work, but you can do resourcing. And I always feel like if I'm engaging them with their body, if I'm giving them a new tool to help them self-regulate, that's time well spent in any session. So that is something we can be doing. The next thing I would say is have the client, identify the positive behaviors, and then have them think about an addictive or compulsive behavior, and use imaginal rehearsal to see if you can get them to use the new thing rather than using the drug. And so they're triggered, you have them imagine using a more adaptive thing, and then they're holding the buzzers or they're self-tapping. After 12 or 24 taps, open their eyes, or you can invite them to keep going. And And if it worked, great. If something got in the way, then just keep adjusting and figuring out how can we use some of this to sort of get you through imaginally this challenge of the craving or the trigger. I like to have the client experiment with this in between sessions. So look, they need to take the skills and use them out in the world. So in real life, they're using the resourcing. And if it works, great. But they should either make a note in their phone, or if you've got a relationship where they can text you or email you in between sessions, they could text you or email you to say, hey, I was triggered to use, but then I remembered I could just take a walk instead, and it passed. And they've sent that to you. You have that. You're then going to bring that up the next time you see them. And it's just another way to sort of have them stick with the experiment and not give up. If it doesn't work, if it's not perfect, that's okay. That's just more data, right? And we just keep working with them to get it better. So I think that we have to have the client describe what they want to have happen in terms of setting the treatment goal. What's the ideal state? And that can be, I want to abstain, or I really just want to modify my behavior. Ask them what they imagine their life would be like in this new paradigm of being free of the substance or being able to not have to go to that behavior. And have them start with eyes closed, tapping and imagining the positive treatment goal. And have them be specific about it. And then ask them, what was that like for you? What did it feel like to walk through the world not encumbered by this addictive behavior or compulsion that is taking up so much of your time? It's very interesting. I think a lot of times clients might know what they don't want to do anymore, but they don't necessarily, they're not doing a natural rehearsal on what it is they'd like to have, what the ideal state is. So it's sort of like, AJ Popke uses a positive treatment goal, or in motivational interviewing, like harm reduction, the client just wants to moderate it. You have them imagine that, use the bilateral tapping paired with the goal setting, and help them engage in the parasympathetic state so they can really see what it feels like to do that. Just practice that, practice the goal setting. The goals may change over time. What maybe was a good goal of just modifying, they can try that experiment and it may not work out. And they may say, you know what, I just think I need to abstain, or I need to cut this behavior out. And then you just keep helping to shape the behavior. So this is going to be familiar to you, but I don't know whether or not you necessarily would always think about it in terms of with addictions or compulsions. So additional resourcing techniques for affect regulation can include a lot of the imaginal techniques we might use in EMDR that go beyond just calm place or maybe container exercise. But starting with something like calm place or safe place, and this is, I think, Corn and Leeds, Parnell, others. You can have them do the butterfly hug or bilateral tapping paired with peaceful place, or thinking about personal strength or resilience or safety. And it's very useful in helping them to be able to tolerate strong affect and not necessarily go to using the behavior, the addictive or compulsive behavior. Pairing it with deep breathing further engages the parasympathetic nervous system, and it can help them stay grounded and have more access to executive functioning so they can make that decision. Maybe I don't want to go into chronic taking or seeking, like in Volko's description, when triggered. Maybe I can be triggered, but then choose one of these other resources. So when they're dysregulated, either through a memory or interaction with somebody who stresses them out, or because a cue has triggered them, they can use calm place or peaceful place with diaphragmatic breathing, butterfly hug, bilateral tapping of some sort to remain calm and more regulated until the urge passes. And even positive cognitions with tapping, thinking in calm place, like I'm worthy, I am loved, I am safe, I know how to do this, I can do this, I know how to care for myself, paired with alternating bilateral stimulation can be enough to help a client stay in or return to their window of tolerance and avoid the unwanted behavior. Container exercise is another very helpful one for when they might, again, get reminded of something, get a text from an ex or something that is going to make them dysregulated and might make them want to use. If they have practiced container exercise in the office with you already, where they have a strong sense of what that container looks like, they know through practice with you that you can take negative thoughts or negative ideas and put them in the container, seal it up tight, lock it, walk away from it, and feel the relief in your body of having put that away and not have that be part of their nervous system. Then container exercise can be really useful in those times when they're not with you or with somebody who can help them. And then some of the resources that we might use in attachment-focused EMDR or just in general, like a nurturing figure, a protector figure, a wise figure, wise self, inner wisdom, highest self, adult self, best self. All of these can be really helpful when paired with alternating bilateral stimulation in office practice, and then when they're out in the world and feeling the urge to use or craving, to start to sort of tap into, oh, I can experience my nurturing figure. My nurturing figure is going to care for me. I don't need to use drugs right now. My protector figure is going to protect me from that liquor store or that desire to walk in the bar, whatever it may be. It's going to be different for everybody, but I think just giving them the awareness and the practice that they have this whole team that lives in their nervous system and they carry around with them all the time, that they can enlist when they're feeling triggered. So, one of the things that I learned early on is that it's probably not enough to be the only resource for somebody who is battling addiction or compulsion, because they are going to be woken up at 2 a.m. by their addiction or their compulsion to go participate in it. And you are not there and you don't want them calling you. That's not a healthy use of the psychotherapy. So getting people interested in, educated about all the alphabet soup of different programs that have evolved probably since, I don't know what, the 1940s when AA first came about. Maybe it's earlier than that, 30s. But since then, Alcoholics Anonymous, Narcotics Anonymous, Cocaine Anonymous, Crystal Meth Anonymous, Sexual Compulsives Anonymous, Sex and Love Anonymous, Overeaters Anonymous, CODA, which is Codependence Anonymous, Al-Anon, as well. And those are mostly abstinence-based models, but there's also Smart Recovery, Recovery Dharma, Refuge Recovery. These are more modifying programs that are similar in that they're organized and you could get to them through Zoom. But I think if you give your clients, or during session, pull these up on your computer and show them what are all the different options, and that with Zoom now, they can access a meeting anywhere around the world at any time of day. What are they gonna, not like about these? What's common? People feel shame. People feel, I don't like to be part of a group. I don't like the way the meetings work. I don't want to, I get social anxiety clicking into a Zoom room or walking into a meeting. I mistrust groups. I don't like the concept of God that I think is going to meet me there. People need to have some more experience with this. And, if they can tell you this, you can rehearse with them how to, bring their curiosity online and not have the knee-jerk reaction of, oh, I don't like that. That's not for me. Because these are really big supports and they may not be for people, but a lot of times it has to do with sort of like these things I'm mentioning, which with some education and with some more resourcing, they can at least try out and try, 6 different types of meetings to see, do any of them match with something that would be useful to them. So I'll help them with the imaginal rehearsal of engaging in the support. I'm thinking of a client of mine who was in other recovery. He was a recovering cocaine addict. And so he could go to Cocaine Anonymous meetings and it was no big deal. And he had a home group, but he was a sex addict. He had big sex addiction issues. And there was an enormous amount of shame about going into a Sexual Compulsives Anonymous meeting. So I would say, all right, we're going to turn on the tappers. I want you to just imagine either clicking into the Zoom or walking into the room, taking a seat, and just sitting quietly, monitoring, listening, and see if you can do that. And I have them do that for 12 or 24 taps. And then I check in. What was going on? How did that go? Was it going okay? No. I immediately clicked back out of the room. Oh, all right. What was happening? What was coming up in your body? What did you notice? Well, I noticed, this pain in my chest or whatever. Oh, can we try it again? And maybe just notice the pain in your chest, breathe into it, try to soften it. And through that type of shaping and sort of continuing to like go step by step, see if you can get them all the way through a meeting or 15 minutes into a meeting. So much so that they are rehearsing and there's the possibility that they might actually go to a meeting before the next time you see them. So I just like to give them the opportunity to imaginally case the joint, if you will, anticipating whatever's going to come up is going to come up imaginally, because that's their fears and that's what they're reacting to when they click in. So I just do a lot of rehearsal with alternating bilateral stimulation and just see if I can get them to consider doing this before, before to give it a fair shake. Because if I can get my clients into the safety net of one of these programs or more, we stand a much better chance of changing the behavior. Another specific time when you're going to want to intervene with resourcing or with specific protocols that are addiction protocols is after a binge or a relapse. So you're seeing your client, maybe there's been some period of sobriety, maybe there's moderate use, and then something happens over the weekend or it's a holiday weekend, there's a big binge, and there's some negative consequence that they come in and see you, and you could just tell by looking at them when they walk in. So, clients who engage in this phase 1 of Volko's binge intoxication, followed by phase 2 withdrawal and negative affect, which is what you see when they walk in, they're going to walk in physically low, emotionally low, a lot of shame, and a desire to avoid the relapse memory. That's where we get to work. I'm thinking of a client of mine who used to engage in crystal meth, amphetamine with sex workers. And whenever this happened, he would be very shameful about coming in because of both the use and also the sex worker piece and etc. So, but that's the time to actually do the work. So here's the tappers. Let's help them reprocess the experience, which is still very much in their nervous system and is, torturing them. So 2 examples, Haas's Cravex and Parnell's Connect the Consequences, both can be useful here. They use level of urge to use rather than a SUDS to measure how strong is the desire to use. And Haas uses standard EMDR protocol, focusing on the worst part of the addiction memory. Parnell does something similar. She also uses level of urge to use as a measure, but she has the client recount the entire period of use, sort of from before first use all the way through at the beginning of the experience, the full experience, and then the negative consequences with continuous alternating bilateral stimulation. Not unlike a recent events protocol. And you could do it once or twice or 3 times with the idea that you're checking the level of urge to use after each time. The important elements of these types of protocols is the desensitization of the addiction memory, which is thought to reduce craving and the level of urge to use, and connecting with the negative consequences, all the way from anticipating using through to the bad consequence. In Volkhaus memory, if you think about it, we're lighting up the addiction memory, including withdrawal, negative affect, and perhaps the use of the bilateral stimulation is quieting the amygdala that we talked about enough by engaging parasympathetic, which allows for that impaired prefrontal cortex to actually enlist the executive functioning of the prefrontal cortex to reduce phase 3 preoccupation and seeking or craving. It's that thinking through the drink. If somebody is engaged in the cycle and you say, just think it through, they have impaired prefrontal cortex. If they are with you and there's alternating bilateral stimulation, they're in their bodies and they're really able to hold both things at the same time. The euphoria of the right brain with then the negative consequence, the consequence which just lives in the left brain. Those are held at the same time. There's more likely to be a change in behavior. So clients have told me that prior to doing something like this, one of these protocols, they never ever told their entire binge story to anyone out loud. And this provided them with clarity. It reduced shame, and it gave them some emotional distance from the experience. I usually tell them that, if you take something that's stored in your right brain and is a secret, and you then move it across and integrate it, bring it through the left brain, including Broca's area, which is the speech center, and out of your mouth, and then to me as a trusted other in the safety of our office, you've now done integration, which is, what you need in order to have a change, both in the way you feel about yourself and a change in behavior. And this type of idea of taking what's secret in the right brain and bringing it through the left brain and sharing it with somebody is what you see in things like in AA or any of the 12 steps where you qualify in front of other people and tell the whole story, what it was like, what happened, and what it's like now. Or even just in a room, being able to share and have people, understand and validate really does help rather than keeping it a secret. So that's where these protocols or this resourcing really helps. The other thing that you really want to do is help address specifically head-on triggers out in the world or internally and craving. So two folks that have worked on this are AJ Popke with the Deter protocol and Robert Miller and his feeling state addiction protocol. And in both cases, Popke is an EMDR protocol to identify and process the triggers and urges. It focuses on desensitizing triggers, reducing the intensity of the urge and the craving, and then it's followed by a positive state with the trigger rather than the desire to use. Feeling state addiction protocol, which is Miller, targets the fixation between a positive feeling state, so not the trigger, but the positive feeling state and the behavior. The client identifies the feeling state linked to the behavior, which is then processed down using EMDR protocol, standard protocol, and it breaks the link. And once the positive feeling state is 0, then standard EMDR is used on the underlying negative cognition. So something that I'll tell you about, which is sort of an innovation of mine that I've used now for a couple of years, and I'm going to show you a video of, is something called Buzzkill. So I began fooling around with like a mashup of a streamlined mashup, I would say, of some of the techniques that I'd learned. So I was able to help a client in one session, change their orientation to the unwanted behavior and develop a new orientation towards a more adaptive one. I called it Buzzkill because the buzzers, clients would tell me that through the buzzing of the paddles, they would experience a killing of the association of the unwanted behavior, and then an affinity for the new one. So Buzzkill borrows from EMDR addiction protocols and also future template or imaginal rehearsal with alternating bilateral stimulation to sever the bond between the euphoric experience, positive emotion, positive body sensation, positive belief about yourself, and the unwanted maladaptive behavior, and then replaces the behavior with a more adaptive one in the same session. I mean, I can often do it within 20 or 30 minutes. And I find that useful, especially if I'm working under the restriction of a 45 or 50-minute session, and I'm not going to do heavy lifting of unrestricted EMDR reprocessing. I can at least help them get some distance or stop doing a behavior that is getting them in trouble. So you start by asking the client, what's the unwanted behavior or compulsive behavior that they have. And they really have to not want to do it anymore. This doesn't work if they're like 80% still want to do it. This has to be something that they no longer want to do. So if the client identifies that the behavior is excessive use of a sex app, let's say, on their phone, the therapist will ask the client, what's the best feeling or emotion you get when you're engaging in the app? And the client might say excitement or validation. And next, the therapist will ask, describe the body sensation that the client experiences when using the app. And they might say, well, I feel arousal or tingling in my chest or increased heart rate. And then the therapist asks, what's the positive belief you have about yourself when doing the behavior? And they might say, I'm valuable. So the therapist then asks the client to bring to mind the positive, the picture of doing the behavior, the positive emotion, the positive sensation in their body, and the belief. And the goal is to bring the euphoric experience and the associated behavior into conscious awareness. Then the therapist asks the clients, when you imagine using the sex app, calling up the emotion of excited and valid with the arousal and belief I'm valuable, how strong is the connection between the positive belief and the behaviors 1 to 10? Let's say the client says 8. Now the therapist asks the client to close their eyes and imagine doing the behavior, begin alternating bilateral stimulation, either tapping or buzzing, which could, and after 12 or 24 taps, I ask the client to open their eyes and say, now when you think about using the sex app and the belief, I'm valuable, did the strength of the connection go up? Did it stay the same or did it come down? And I repeat this procedure each time, asking only about the strength of the connection between the behavior and the positive euphoric state. If you get into what's coming up, it can start to get pretty wide. This is a restricted resourcing protocol. So time 0 was a connection measure of 8. If I do it after time 1, after the 12 or 24 taps, how strong is it now, 1 to 10? Maybe it's gone up to 9, or maybe it stayed at 8. I keep doing that, just focusing on, did the connection between the behavior and the positive state go up, stay the same, or come down? And before long, what happens is there's a falling in the connection measure as more reason and logic comes online with perhaps more left brain association. Also, guilt or shame may begin to come in to make the behavior less desirable. Before long, the client will say, it's a 1 or a 0. And now I don't see the connection between the behavior anymore and that feeling. And you can ask, okay, is there another behavior that's less problematic or healthier for you that results in your feeling valuable? So the client will say, here's this other behavior instead. So now we've identified the new behavior. We ask them to imagine doing the new behavior and again, start the tappers. Allow the tappers to go for 30 seconds or more and check in with the client. Once, or ask the client to imagine it all the way through and then check in. Can you imagine substituting this behavior the next time you're wanting to feel valuable? And if necessary, can you continue to work with that using alternating bilateral stimulation to reinforce the new behavior? they'll say, yeah, I can imagine that. Or no, not yet. Would you like to strengthen it? Yes, let's do some more. So you do that. And how does that feel? Yeah, I actually feel like that could work. So next session, you check in with them on whether or not they engaged in the undesired behavior, or whether it's less, or if they're able to use the adaptive behavior. That's a description. Let me show you this in action in a video. Again, this is a client of mine that I've worked with for many years. He's very generous. He always gives me written permission to use his image because he feels very strongly in terms of the work and the benefit he's had and how he wants to share it with other clinicians to give other patients that benefit. So I just want to make that clear. So let me stop sharing my screen for a minute. Let me go to this, and then let me share my screen again. Okay. And now I will play the video. Okay, so why don't we try doing a little bit of buzzkill on this unwanted behavior? And again, the unwanted behavior is because of your contract with your significant other, you want to not be looking at images of women in sexy clothing or something like that. Is that right?
Yeah. So
okay.
Yeah.
All right. So if you think about going to look for those images, what's the positive emotion you get when you picture yourself doing that behavior, to going to looking at the images?
I feel I just feel like I feel drawn to just decouple from uh, my mind. My mind's just racing to try to keep trying to figure out the problems of that I can't figure out, that I know I don't have a solution for, and it just feels like it's interrupting it.
So the positive emotion, is it relief, or is it numbing, or?
It feels just straight up interruption. Like it would feel like, I guess, relief feels like almost too far a bridge. It just feels like a pausing.
Okay, so pausing on anxiety or whatever.
Right. Pausing on anxiety, pausing on the compulsion, the desire to try to figure this out, and going like I've been thinking of, I've lost a whole night's sleep. I got up and it's immediately the needle's back on the record, playing that same track, and
Yeah.
I just want to pull the needle off. That's about it. I just want to stop the record.
Yep. So all right. So that's the positive emotion, is sort of the interruption of the stress, or the interruption of the sort of behaviors that you're kind of going through right now as a new dad of twins. So what is the positive body sensation when you think about, when you sort of picture yourself going to some of those images, those erotic images?
I mean, it really just feels kind of primal, and or let's not even go primal. I guess it's just because this has been a thing that I have felt like it's a safe thing, even though it's not a mentally or emotionally good thing for me over the history of my life. It seems like it's been a way of detaching or escaping.
Mm-hmm.
And so the positive feeling is like I'm taking control. I'm choosing to do this.
Where do you feel that in your body? Where do you feel that positive feeling of I am gaining control over this?
And strangely, in like my obliques above my hips, kind of like this kind of sturdying of the lower abdominal muscles, almost like a gird. I guess that old saying, like, what a gird your loins means. But it feels like I'm strengthening my stomach. I'm saying I'm
Yeah.
almost feeling like that region is willfully in a positive way feeling stronger.
Yeah, I got it.
Also,
So when you
yeah.
no, you're doing great. So when you think about doing the behavior of going to look at these images, with the positive emotion being sort of a pause on all of the kind of relentless stress, and the physical sensation is sort of like a girding of your loins, if you will, above your obliques, some sort of tightening in your body. What is the positive belief you have about yourself that goes along with this behavior?
I guess it's not so much worded. It sounds funny when I put it in words, but the feeling is like I can control my body. I'm in control of my virility, my strength, physically.
Okay.
I have a choice to feel aroused, I guess, or I have a choice to detach by way of being. It just feels like I'm more. It feels like a less healthy version of. It's an easier, less healthy version of doing the work of going for a run or being in my body, like by way of exercising or by way of just physical presenting of some way. Like, but I'm saying, oh, this is me, and it has a masculine edge to it too, or at least a sexual strengthening to it.
So
where I'm like, I got this kind of thing. I'll do this with me.
So the positive belief is sort of like I'm in control. I control my own body. I'm a man. I have agency. I don't know what would you say is sort of the belief that the positive belief that sort of underscores this behavior of looking at the images with the associated emotion of lessened anxiety and the girding or the protecting of your core or whatever. I don't know.
Yeah,
I'm
in control right now.
I'm in control. Okay.
I'm in control, or at least it feels like I'm in control of my body.
Okay.
I mean, the brain, it's almost like I'm putting a Novocaine into my or a stop or a pause into that cycling where I'm mentally focusing and then physically presenting more on my body than on my problem I can't solve, that I can't touch, that I can't see your face.
So let's do the following. I want you to, if you think about I'm in control, and you think about doing the behavior, how strong is the link between doing the behavior and I'm in control, 0 to 10? How strong is the intensity of the link between those two things?
I think the strength is the relationship is subject to the distress that I'm feeling. I think it shifts.
Well, when you think back to doing the behavior
at that particular moment,
yeah.
No, I mean, it's funny. Like that's what when I said we were doing an aversion, I was like, oh, I don't feel good about this now. But I mean, as it goes for feeling the agency in that moment before pulling the thing, selecting images, or like even doing the search or web search or whatever, like there's a strong feeling that I am now. It's like a 7 or 8.
Okay.
Number wise. It feels like a unified choice. We're like shutting this fucking brain off. You know.
So let's do some. Let's put your hands in sort of butterfly.
Oh, I've been doing it.
Okay, fine. All right, great.
Tragic.
So think about doing the behavior and just start or keep tapping, and I'll check in with you in a moment.
Even if I didn't go there, like just imagine if I did.
Imagine doing the behavior. Yeah, imagine doing the behavior, or imagine the search. Whatever you want to consider the part that's unwanted. Like if you want to avoid even getting into the search, then that could be the behavior that you want to avoid. But imagine doing the behavior, with the sort of belief of I'm in control of my body, and just do that for a moment, and I'll check with you.
Okay.
Okay, and now open your eyes and stop tapping. And just let me ask you, when you think about doing the behavior now and its connection to I'm in control, did the intensity of that connection go up? Did it stay the same or did it come down?
It feels like it came down.
Okay, so where are we now?
Where-
If it was a 7, where do you think it is now?
It was like it's like a 5 or 6. It's almost like I'm in a arc. It's like I wanna believe what I've always think is gonna give me what I want, but I'm starting to feel smaller. I don't know if that sounds normal or not, but I feel like I'm aware of where I'm at, which
Okay.
is good, which is probably like, at least in that moment, the first time I'm aware fully of the room I'm even in, because I'm so not even realizing how dissociated I've been, at least recollecting it now.
Yeah.
Yeah.
All right, let's try it
So
again.
about 5.
Perfect. Let's try it again. Start tapping, think about doing the behavior, and I'll check in with you in a moment.
Okay.
Okay, and if you stop tapping and open your eyes again, come back to the room. Now, when you think about doing the behavior and then that positive belief of I'm in control of my body, did the intensity of the connection go up? Did it stay the same or did it come down?
It came down and it felt like I've got something in my throat now. It's down at around a 3.
Okay, all right.
It feels like there's not a lot of truth to that statement.
Okay.
I feel like I'm starting to feel like some guilt, and I'm also feeling like I'm a million different other things coming in. Like I'm not just the egoic template that goes to this thing, this behavior. I'm not just the one-dimensional guy that's gonna take control back. I feel small. I feel like I'm in a weird way. I feel like ashamed and feeling guilt. And the other thing is like, oh wait, I'm my partner's the person they love. We made this choice together. We're like I'm dad, and I got a lot of other things I got to do, and I don't know, like some other stuff just starts coming through the strainer. These are like I'm not just one thing. I'm not just a guy that's trying to avoid the fire.
No, it sounds like you've got, you got both sides of the brain working now, and that's great. So let's try it one more time. Just start tapping and imagine doing the behavior, and just I'll check with you in a moment. Okay, and if you take a deep breath, open your eyes, come back to the room or to the car. And so now when you think about the strength or the connection between doing the behavior and I'm in charge of my body, did the intensity of that connection go up? Did it stay the same or did it come down?
It's down. It's at a 1. It's like a full realization again that there's no control in this behavior. It's an addiction. And I feel quite sad that, but I also am not. Sorry.
Okay.
Yeah, I feel very, if I turn my mind's eye to even imagine looking at the images, it's an attachment, it's an addiction, and it doesn't feel strengthening. It doesn't feel like I'm making this choice. I don't feel free at all. I don't feel good about it at all.
So it's still a 1 though? There's still a 1 of a connection?
Yeah, because it's still like that. I think the thing that always tends to remain is a very childlike version of me that goes, but I still get a nice puff, right? Like I'm addicted to this, but it'll still interrupt the thought.
All right,
let's try. It's almost like a guilt-laden version of you're not in control, you're addicted, and it sucks, but just do it. Your brain will be quiet.
Yeah, there's a reward there still.
Yeah.
All right, so let's try
Yeah.
it one more time. Just close your eyes, imagine doing the behavior, and let's start tapping again. And I'll check with you in a moment.
Okay.
Okay, if you open your eyes and you come back. So now when you think about the behavior and the positive belief, is the connection between the two, did it go up? Did it stay the same or did it come down?
Down at zero. The bottom of it, I probably just got to remember this, write it down somewhere. The bottom of it is love and loss. The bottom of it is love and loss. Like, I love my partner. I will lose my partner if I choose this behavior. I love her and I will lose her. And I don't want to lose her. And I don't want, and not even out of selfishness, but I love my life with her. Like, I love our kids. And I understand, I don't understand the pain I've put her through. And I don't understand that. And I don't understand how much I'm even losing out. But I just don't want, I mean, there's a lot of sadness, like a lot of sadness. And I just feel like that would be what I'm trading it for. Like, some, something.
So
like
would you,
that.
so are they, so
like
are they,
shut my brain off.
so are they separate right now, Frank? The behavior and then the idea that I'm in control, are those now separate thoughts? They're not connected anymore? Okay. So
They feel like football fields away right
all right.
now.
Perfect. So let's think about what can we do as an adaptive replacement behavior to give you a sense of, to give you that feeling, that positive feeling of I'm in control. What's another thing that we could do instead in those moments or in this moment now that we can explore that would help you feel I'm in control?
I'm like laughing and crying
Yeah, that's okay.
because I'm like, I found a new thing I like. I don't even know if I like it. I like that my family likes it. It's not really a gift I give to myself, but like, I love cooking.
Okay. Okay.
Like, I love it. I don't like cooking, but I love that my family likes that I cook. I like that I'm getting better at it, and I feel present in my body when I do it. And I like that there's autonomy when I'm cooking. Like, we have a rule in the kitchen. It's like whoever's cooking stays out of it. So I feel like I own that space. It's mine for however long I'm making food. And I'm making it not to drag it out, but I'm making it like thoughtful. I want it to be not take forever. I want it to be tasty for my family. And I feel embodied. I feel like, all right, I've done some really dumb stuff when I was just learning to cook, and at the ER because I cut my finger. I'm not, when I'm fully embodied doing that, I don't feel bad. I feel good, and I feel like I need to be good. My wife likes sharp knives.
So let's imagine you using the sort of fully embodied owning, being in control of yourself and your immediate surroundings through cooking as a positive adaptive behavior. And what I want you to do is start thinking about that and start tapping, and let's try to resource that or reinforce that as a way to get to I'm in control.
Okay. All right.
Okay, and if I ask you to open your eyes and come back,
How does that feel? What's that like?
So good. It really is. It's like, because it's so recent that I don't know, it's just recent because I'm, you know, needing to cook because of my partner being pregnant,
Mm-hmm.
and having to get better at it quick,
Mm-hmm.
and getting a lot of hard, sometimes emotion-filled feedback from a hungry mom, forced me to get good quick. So it's like an easy reference point to like how such a short time ago I was just all right. And I'm not great, but I could feel like when I'm standing there and I actually know how to chop the vegetables faster than, you know, like you can literally just feel yourself getting older waiting for me to make a salad before. Now I'm like, oh crap, I gotta hurry up. And it's done well. And I feel like it's a really positive resource because I'm like, oh wow, I feel like I got good and I can reference easily in my memory how I wasn't so good before. And that makes me feel even better. And then when I put it on the table, it's like if like they like it, it's like even a bigger like ego hit, like, oh wow, I gave them something, they enjoyed it. I provided a basic need that is something that only I can do because she's feeding the babies right now. And if they like it, that's like icing on the cake. And if they don't like it, I got tomorrow, or I got, lunch or dinner or whatever. But I don't know. It's like funny. It's good.
Does this do the trick in some way in terms of giving you some positive feeling state associated with either control or having a moment to yourself or having a moment where you are being effective or where you're taking the needle off of the record that's been ongoing? I mean, can this be a substitute positive adaptive behavior?
Yeah, definitely. I mean, it's nice that it happens 3 times. It happens 3 times a day. Like meditation is amazing, and I can do it. It's just that people don't need it from me. Whereas even if like it's like 2:30 in the morning and I'm like, oh, I can't sleep, oh my God, I want to like go into, just connect by way of, looking at crap on the internet. Like I could do meal prep. I could chop vegetables. I don't know what I could do.
Yeah.
I mean, I can quietly. It seems like a really attainable redirect.
All right. Do you want to try to strengthen it by imagining a little bit more of a tapping?
Yeah.
Okay. Yeah, good. Good. Keep imagining doing it. Keep imagining it being the thing that you can go to, your new go-to behavior for when you want to pause and do something that makes you feel in control and good about yourself. Okay. You want to open your eyes. How's that feeling?
It feels I just got a cherry on top because I just realized how much creativity I get to enjoy with this new thing. Like,
nice.
It's cool. It's cool. I literally just remembered a recipe that I just learned, and I'm like, oh, wow. I'm learning new things too. Like, and I got to throw my own. It just feels like I get a creative voice out of it too.
Yeah.
Yeah.
Nice. Awesome. So was this useful today? Sort of working through this unwanted behavior and coming up with an adaptive, positive behavior that you can use instead.
Yeah, it's great. It's like I didn't even realize I've already been doing the positive behavior to overlay that old template,
Yeah.
or whatever, however you say that. It's good. It feels good, because I can't get out and exercise like I used to, like all this other stuff. But you got to eat every day, right?
Yes.
So that's good.
All right. Well, perfect. Yeah. I am going to just stop the recording.
Stop the share and let me share my screen again. Okay. So So I hope that was illustrative and sort of shows how resourcing in this restricted way can really help with addressing an unwanted behavior that, in this case was really getting him in trouble, incredibly dysregulating for him and for the entire family system at a point where they really need to not be distracted by this kind of thing, and giving him a dopamine hit that is great. The adaptive behavior in this case was so much better and was nourishing literally his family and his relationships with his partner. So that's pretty much the presentation. I hope this was useful to you. I hope you got to see that by using EMDR and specifically elements of EMDR that focus on resourcing in a slightly more restricted way than not to say that we don't, with addiction and compulsion, do unrestricted, full-on standard protocol. Absolutely. But it's often not what we need to do right away. We need to sort of work on shoring up the system, having people have many more resources before you take the plunge to go back to some larger early memories. So anyway, I hope I gave you enough examples that you can use some of these. And I think I'm should tell you not to, please submit your post-program assessment and survey so you can get your certificate of completion at the end. And yeah, that's me. That's how to get in touch with me. And I think we'll go to questions now.